Okay, hello everyone. Thank you for joining today's program, Barriers to Screening Roundtable Discussion. My name is Kristen Power, Director of Communications at the Nevada Cancer Coalition, and I will be serving as moderator for today's webinar. The Nevada Cancer Coalition presents this webinar with funding from the Nevada Division of Public and Behavioral Health's Women's Health Connection and Colorectal Cancer Control Program. So before we get started, I wanted to go over a few housekeeping items. First, please make sure that you're logged into the webinar using the link that was provided in your confirmation email so you can follow along with the slides. That's where we'll have the discussion topics. Because we're having a discussion today, I will be unmuting all the phones, so please feel free if you have background noise happening where you are to mute your phone from your desk while you're listening and then unmute it to join the conversation. Also, as a reminder, don't put the call on hold so that your hold music doesn't broadcast on the call and disrupt the audio. There are a couple of ways to jump into the conversation. You can use the raise hand feature, and then I will call on you and try and get you into the conversation. You can also type into the chat box on the lower left-hand side of the screen, and then we can conference you in that way, or you can just jump into the conversation if no one's talking. The value of this webinar really depends on your participation in the discussion, so please feel free to jump in with any experiences, comments, suggestions. A recording of this presentation along with a link to the post-test, because there is a post-test, will be available on nevadacancercoalition.org within 1 day. Click to the Healthcare Providers tab and select the Cancer Screening Training Modules option. If you're pursuing the Nevada Cancer Coalition's Cancer Screening Certification, please be sure to complete the post-test to receive credit. All webinars and post-tests listed for each module must be completed to receive a certificate. So with that, I think we're ready to get started. I'm going to unmute phones, and then we have several barriers that were submitted ahead of time, so we're going to start there. If you have additional barriers that you'd like to discuss, you can type those into the chat box as well.
The conference has been muted. The conference has been unmuted.
Okay, so we're going to go ahead and get started with a barrier that was submitted to us ahead of time. And it is that a challenge some partners are working on is reducing time from diagnosis to treatment. So some patients don't meet financial requirements for Medicaid or the Access to Healthcare Medical Discount Program, and then they fall through the cracks, unable to pay for treatment. And many of them are undocumented, but some are not. So does anybody have any resources you are aware of to assist these women, and any suggestions on how we can better, as partners working in the same field, work to share those resources with patients? Don't everybody talk all at once. Has everybody heard, is everybody connected with Judy Padilla from the Governor's Office of Consumer Health Assistance? Okay, I'm going to take that as a no. So I'm going to suggest that that is a good place to start for people who are looking for access to treatment. Judy Padilla is from the Governor's Office of Consumer Health Assistance, and she really serves as a case manager for a lot of clients. She works with a lot of different clients and can direct them in the different resources, especially those within the state related to getting insurance, getting treatment. She has a lot of connections at different health facilities. So that's one good option. Does anybody else have any? I know in Nevada we don't have a lot of resources. Well, let's skip this barrier and we'll go on to the next one, and then we can come back to this one. So this one is another one related to funding. Funding sources can sometimes run dry, causing a stop or a hold on getting uninsured patients screened for breast, cervical, or colorectal cancers. So has anybody developed any resources or tactics to continue referring patients for screening if the programs have a hold on screening? Oh, Jessica, go ahead.
So I was going to type it, but I'd rather just speak. It's easier. We have a sliding fee scale here at Hope. And so what that allows us to do is say if there is no more funding or we run dry, we can always use the patient sliding scale to help them pay for it. So say if a patient is in slide scale A, they would only pay $10 for the fit test. So, I mean, that one helps at least with the fit test, not so much with the colonoscopy, but, you know, we're able to get them screened at least through a fit test first, and then if that comes back abnormal, then we can always wait to get them screened through the colorectal cancer program if they qualify for it for the colonoscopy.
That's a good idea. Do you have any sort of sliding scale as well for, like, mammography and breast cancer screening?
Yeah. So in regards to the mammography, we actually work with we work with Coleman and Renown, so we have two funding sources that could potentially help with that. I would have to ask Isabel in regards to, you know, if we run dry, what would be the process with that. But even then, we work pretty close with RDC, and sometimes they can provide our patients lower prices if they're to pay in full, and even, you know, if they're to make payments, it wouldn't be like the full price than if the patient were to just walk in.
Thanks, Jessica. Does anyone have any other, has anybody formed a relationship similar to what she said with a mammography facility for discounted or sliding scale mammograms? Or colonoscopies? Lily, I think you had your hand raised. Did you have something to add?
No, I just had too many screens open. Sorry. It was clicking in the wrong places.
Okay. And I've gotten a few comments that there's a little bit of feedback. So if you're not talking and you have the ability to put your phone on mute to prevent feedback and background noise, you can feel free to go ahead and do that, just so we can keep the background noise to a minimum. Any other tactics that people have had for getting people into screening if they run out of funding in their program allotment? All right. Well, we will move on to the next one. We can always come back to this if something comes to mind.
I have one more to add to that one.
Go ahead.
So I've actually gone into the Colorectal Cancer Alliance, and they offer, I guess you would say it's a financial assistance program. I've only had two patients that have actually gotten awarded, but it's called the Blue Hope Financial Assistance Program. And what that is, it basically provides assistance for colorectal screening or treatment. So you have to fill out an application for the patient, and then the patient will be contacted. And it could be either $300 to assist to the either colorectal screening or $200 towards colorectal cancer treatment. I believe it's only a one-time thing, though. They do kind of go based on income level. But like I said, that's another one that I'm pretty sure a lot of people don't know about. And that one I kind of found just, Googling resources through the Colorectal Cancer Alliance website.
Oh, that's a fantastic one. That's a great idea for perhaps we will do some searching to see if there's a similar program for breast cancer screening or Pap testing. Thanks, Jessica. So we'll skip ahead to the next one. If anyone comes up with anything with the previous one on getting people into screening, feel free to circle back to that. But the next one really deals with cancer screening guidelines, and I think is especially topical based on the latest update to colorectal cancer screening guidelines from the American Cancer Society. And this one is related to varying screening guidelines for breast, now colorectal cancers, that patients are sometimes skeptical about the importance of screening. And if we can't decide when someone should start screening, is it really important at all? So what are some ways that you have found to overcome these reactions from patients and reinforce that screening really is important? Has anybody found something tried and true that they can talk about with patients to encourage them to get screened despite confusion over the guidelines? Okay, well, I'm going to start because I did a little bit of research on this today. So especially related to the latest guidelines for colorectal cancer screening, American Cancer Society indicates that people should start screening at 45. And that used to be our easy cancer because we just had one consistent guideline. And what I found was that really the difference between some of the screening guidelines include differing ways of weighing the harms versus the benefits. So one organization may give more weight to certain harms and less weight to the benefits of screening. And then some may weigh the benefits as more important than the harms. There's also a reminder that the guidelines focus on women with average risk, and that those are different. The screening guidelines may be different for women with higher risk or family history. And another point I think that's important to make to patients is that organizations use different data in making their recommendations. And I thought that this was a really important one because organizations may be looking at different studies and different data points and then making a recommendation based on what they've used. So the guidelines from the U.S. Preventive Services Task Force and the guidelines from the American Cancer Society may be kind of apples to oranges. And it looks like we've got a couple comments here on this one. One is that for the colorectal program, screening guidelines aren't changing. And that's a good thing to remember, is that when we're working with Women's Health Connection and the colorectal cancer screening guidelines, we still follow the USPSTF guidelines, which are screening starting at 50 for colorectal cancer. And then with the Women's Health Connection, we have actually two pots of money, so we can start screening at 40, but USPSTF still says 50. So that's a little bit different in that program, but with colorectal cancer, we do still stick with the 50. Looks like, Jessica, you had a comment as well that science and medicine is ever evolving and new things are found all the time. So what was recommended 10 years ago may change, and I think that that's a really good point too. As we get more research done and we have more data available, the research may show that updating the guidelines is important. So great point. Anybody else have anything to add on this one? Any talking points that they share with patients if patients question the guidelines?
This is Lily, and I just have a question. I'm not in patient care, and I hear that this is always a problem, or I see it in research and papers, but is it actually really a problem? Do patients bring it up that much, or is it something that's easily overcome with a statement like, well, yes, they get updated because the science has improved?
Does anyone in patient care have anything to add? Has anyone had a real challenge with anyone kind of arguing the importance of screening. It looks like at Nevada Health Center's Cambridge Clinic, it's pretty rare to have patients questioning age requirements. Good. Hopefully providers are making a strong recommendation, and so I think with a strong recommendation for the provider, that might also limit a patient's questioning of the guidelines. All right, we have a really quiet group today. Please feel free, I know it's after lunch, but please feel free to jump in with any sort of comments. Raise your hand, jump in chat. This is all for everyone's benefit. So we'll skip to the next question. If anybody has any thoughts, we'll circle back again. So you all are likely cancer screening champions in your clinic. However, patients routinely interact with many staff that may not prioritize early detection as you'd wish. In webinar 2 of our series back in February, we heard from Beto that orientation and ongoing trainings with staff are opportunities to get medical assistants, nurses, and other clinical staff on board with cancer screening programs. Has anyone else tried other ways to encourage support from the entire clinical team, or has anyone implemented orientation or training and had any feedback to provide on that? And I guess another add-on question to this is, has anyone been able to kind of work with the rest of the clinical team to create orientation or to help provide that educational material for orientations or trainings? Suleika, do you want to tell us a little bit more about what you're working on?
Hi, you guys can hear me?
Yeah, just speak a little bit louder.
Okay. Good afternoon, everybody. This is Suleika from Nevada Health Center's Cambridge location. To piggyback what you were saying, here, whenever we get a new hire for medical assistant, regardless of their location, they come through the CHWs for training. We've set up something with the nurse educator. We created some content, some material. Obviously, we want to screen them for the clinic that we report on for our grant, but everyone, regardless of specific sites, they come through us, and we, give them the little spiel about the CRC screening, and then they leave with the educational packet. For when they're on the floor, they can always reference it to it.
So you have a packet that you provide them?
Correct. A packet that goes over the screening age. It's basically like a 101, like what is colorectal cancer, who it affects, the age group, the age that screening is supposed to start, and what type of screenings we offer, how to place the order, and all that stuff.
Oh, fantastic. And is that a new program, or have you been doing that for quite a while?
We started about a year ago. About 1 year ago. So basically, because you know how the grant allows us to move from clinic location. So when we encounter the staff that we've trained before, of course they're not going to remember, but when we go back and retrain them, it's like a little refresher.
That sounds really great. And it looks like Maria jumped in as well at Henderson. It's also part of orientation. So it sounds like all the Nevada Health Centers have incorporated that into the orientation for MAs. Jessica, do you want to jump in with what you guys work on?
Yeah, so basically what we did, all the, I guess you could say, care coordinators here at Hopes, we did our own PowerPoints, and in those PowerPoints we educated the MAs and nurses what it is that our programs do for a patient, like what we can offer and who qualifies for it. And then another thing that our clinic did was provide us with walkie-talkies so that the MAs, if for some reason they can't give the educational piece to the patient, they can always walkie-talkie us to go into the room without them having to come all the way in the back where we sit to get us. So that's a couple things that we've done to kind of help with that. And then another thing that we added to the colorectal program is we have a tablet. So if the MA is too busy to provide the education and I'm not on hand, they can always provide the tablet with the education of why it's important to get a colorectal cancer screening, as well as how to do a fit test. And they can give that one to the patient. The patient can view it while they're waiting for the provider to come in and see them.
So I have a question for you. If the MA calls you in on the radio to come in and talk to the patient about the screening, does the MA stay in the room and listen to you talk to the patient so that maybe they learn some of the skills in that conversation?
Well, usually if they call us, it's because they're busy and they can't get to the educational piece. But all of our MAs have to come through us first before they can get allowed to start rooming and see patients. So they all have to spend at least an hour with us learning about the program and getting educated on the program, and then we provide all the information, the educational pieces, why it's important, how they're supposed to approach the patient about the I guess you could say the programs that we offer here. And so that's one of the pieces that they need before they can go on the on the floor, as we call it. So we don't just send them out uneducated. They have to get education from us, and then they'll be allowed to room patients.
Fantastic. And it looks like Maria, go ahead.
I just have a question. This is Maria from Nevada Health Centers, Henderson. How did you guys get the tablet with the information for the patient? Was that provided for you guys, or is that something that you guys put together?
So that's something that we requested through the grant.
Jessica, would you be able to share what exactly you have that you put in, like if there's a specific list of items that are saved on the tablet that are used?
Yeah. So we basically on the tablet, what is saved is the the informational pros and cons in regards to the fit test and colonoscopy. And then we also give them a video depending on their fit test, because as you know, LabCorp uses one and then Quest uses a whole different one. So we have both videos available depending on their on whatever lab they go through. So if it's the fit test, then of course they get the one for the one with the little brush or the little straw thing. If it's Quest, then they get the one with the two-step brush, which now has changed into one-step brush. But those videos are the ones that are saved there, and basically all the MA has to do is click on the video, push play, and it'll play for them.
Do you offer the video in English and Spanish?
Yes, we do. So I had to do my research, and I found a lot of them through YouTube. So once they were approved by our providers, that they were educational enough to where we could use them for the patients, then that's when we went ahead and saved them on the tablet.
And then we actually just had a meeting today, we're working to add them to our Stratus, which is our interpreting program that we use here, which is on a tablet as well. So we're working on incorporating them into those tablets so that if, say, the tablet that I have back here is not available, then we also have a tablet in each adult and pediatric pod to help with that. That way, they're not fighting for the tablet or they're not fighting for me.
Excellent. Thanks, Jessica. Any other questions on how HOPES is handling that? Anyone else have any things that they've tried out to encourage support from the rest of the clinical team on getting people screened? Jessica, I have a question for you related to this as well. So it sounds like you're using this specifically for colorectal cancer. Have you, has the team considered doing something similar or implemented something similar for breast or cervical cancer screening? For example, a demonstration video on how a mammography is performed or how a pap test is performed?
They haven't. So we haven't really discussed it, only because the tablet that I have is specifically for my program, because my grant paid for it. But the Stratus ones, those are actually they come out of the clinic grant. We could definitely pitch it to to our coordinator here and see what he thinks of it. I mean, the only reason, I don't know, I guess the only reason we wouldn't really do that is because we wouldn't necessarily be doing the mammo here. They have to go to RDC or Renown to get that done, and they usually do a really good job at telling the patient what to expect. In regards to the PAP, then, I mean, we can definitely maybe show a patient what the PAP is going to look like or what they're looking for in a PAP. But, I mean, most of the people that come to get the PAP, they've had it before.
Okay, that makes sense. Excellent. All right, well, we're going to hop to the next question. If anybody has anything on this one or any of the previous questions, feel free to jump backwards. This kind of relates a little bit, this ties a little bit to what we were just talking about, but has anyone encountered any challenges to screening because different community health worker staff manage clients? So you have one person working on Women's Health Connection and one person working on colorectal. How do you work together with the community health workers on the other programs so that you can make sure that you're not missing opportunities? Say, for example, a woman who's 50 comes in and she gets referred for a mammogram, but you also know they need to get screened for colorectal cancer. Has anybody encountered barriers to that because we have different staff working on different cancers? Jessica, go ahead. Oh, wait, yep. Yeah, we'll go Jessica first, and then we'll jump to Casey.
So all of the care coordinators here sit together. So usually, like, say, if Suseli, who runs the Women's Health Connect, has a patient that she knows might qualify for the CRC program, she'll let me know, and she'll let the patient know as well. She'll be like, oh, well, we have someone here that provides this for you. Would you be interested? Can she give you a call? And then that's when, I'll go ahead and call her. We can always catch the patient when she's here as well.
Excellent.
But we literally sit, like, right next to each other, like, back to back.
Okay. And Casey, go ahead.
Well, my coworker does the CRC program, Eddie Lopez, and he is also bilingual. So he's a great help to me with my Spanish-speaking patients. And then we do a pre-visit report. We pull these reports from our computer system the day before. So we're signaled which patients need to be seen for. I do women's health, so I know if they're ordered for a mammogram and they haven't had one, or whatever the case. Maybe they had an appointment and they missed it, or something like that. And also for cervical, of course, we can't order pap smears ahead of time, but if they're due, we're alerted to them as well. And sometimes when we go into their charts and we see, that they're missing these screenings, you can say, oh, it doesn't look like they've had a fit test or a colonoscopy. So the two of us can work together that way. And we do sit near each other, and in our clinic we have 3 different pods where we can sit and work with the providers and the MAs. And yeah, so we have easy access to each other and pretty much know what the other one's doing all the time.
Excellent. Teamwork makes the dream work.
Yeah.
And it looks like in the case of Rosina, she's an ELCO. She handles both programs, so it sounds like she doesn't miss any clients. Does anybody else have any challenges or opportunities or ways that they've found to really work with the other program staff in their office to make sure they're not missing opportunities? Sounds like the buddy system is the way to go.
Yeah.
Okay, so those are all of the barriers that we had submitted ahead of time. So I want to give us an opportunity to either have anyone share any other barriers that they've encountered recently that perhaps they're looking for some input from the others on the call, or we can go back to any of the previous ones that we've discussed if anyone has any thoughts that they've come up with or suggestions. Or if there's a barrier, perhaps that that we can do, that the Nevada Cancer Coalition or some of our partners from the state that are on the call can do additional research on and then provide feedback to everyone, we'd be happy to do that as well. Ooh, great one, Jessica. Transportation to colonoscopy procedures. So I know one of the challenges with transportation to colonoscopy procedures is what we've heard is that at times the gastroenterology offices want the person who is dropping the patient off for their procedure to stay the entire time that person is going to have the procedure so that they can then drive them home. They can't really drop them off and then leave and come back. I'm not sure if anyone's encountered that challenge, which makes Ubering to your appointment difficult. But has anybody found any winners when it comes to transportation to colonoscopy procedures? Jessica, on your question, to clarify, is this partly due to the driver needing to stay with the patient?
So yeah, so the driver having to stay with the patient would be one, and then another one would be that the taxis won't they won't do it. They just don't want to be held accountable for having to watch a patient for up to 2-3 hours after the actual procedure. I know, like, we offer transportation here, but when it comes to an actual colonoscopy, we can't do it for liability purposes. And I know Access to Healthcare does it, but they have to have, like, say, like a chaperone. But that would only be for, like, Access to Healthcare patients. So what I want to know is, like, has anybody used another thing? I was looking into Uber Health, but we're still trying to get someone from Uber Health come talk to us here at the clinic and see, what kind of liabilities we're talking about, what kind of insurance stuff they need. Is it just anybody randomly that goes pick up the patient, stuff like that, because they're supposed to be able to transport patients to colonoscopies, procedures, surgical stuff like that. But we want to know more before we can actually, just hand over our patient to Uber Health.
Right. Casey, you've got your hand raised. Go ahead.
All that we're able to offer is gas cards from our grant. And sometimes that's enough, but, obviously a colonoscopy, that's kind of an important issue. And I wish Eddie was here. He may know a little bit more about what kind of research he's done on that. But I did hear we might get Uber in the future. But right now we just offer gas cards, and that seems to help a little bit, but it's not, the whole answer to the transportation issue. but it's helpful.
So one thing that I'm aware of is recently the American Cancer Society expanded their transportation assistance program, and part of that program has volunteer drivers. I could do some more research for everyone to see if the volunteer drivers for that program are able to also wait for a patient when they get a colonoscopy and then drive them home. But has anybody explored looking at a volunteer opportunity for people interested in volunteering with their organization that might be able to kind of volunteer to be that person's, that patient's companion for their procedure if it's a person that doesn't have a companion to support them for that day? Sounds like no one has that. That's something I will do some research on and circle back to everyone because perhaps that's an opportunity. Even if the person that is the companion isn't able to drive the patient to and from the procedure, perhaps combined with the Uber options or the gas card option, it would at least then cover the companion portion of that barrier. We'll check into that and then circle back to everyone because here at the Nevada Cancer Coalition, we do have people reach out to us for volunteer opportunities, and we know that the American Cancer Society has a large base of volunteers with their organization as well who do different sorts of patient activities. So perhaps that's an option for everyone. We'll check into that and circle back. Looks like Rosina's got some feedback on discounts for cash patients. Rosina, what's your comment? Which barrier is your comment related to?
I would say the very first one.
For treatment or getting people screened?
Getting screened.
Okay.
Well, the hospital will do the treatment and getting screened.
Mm-hmm.
They do a 60% discount for cash paying patients. And then for our PAPs, we have a Title 10, which is a family planning program that pays for the PAPs.
Oh, fantastic. And are there age guidelines or restrictions on who can access PAP testing through the Title 10 funding?
The same age as the women's health, except they have to be childbearing years. Yeah, within the childbearing years, because it's a family planning program.
Okay, that makes sense. Great feedback. Thank you. Does anyone else have any other new barriers or thoughts on the ones that we've already discussed? Quiet group today. Does anyone, Jessica, go ahead.
So my question is, has anyone else used the MTM, Nevada Non-Emergency Transportation, for rides to colonoscopy procedures?
And Jessica, what did you call it? It's the Nevada Transportation Network?
Yeah, I think it's called like MTM. It's MTM, Nevada Non-Emergency Transportation. I know usually they'll go through that company if, like, say we can't provide a patient with their colonoscopy or GI consult because, say, their insurance doesn't pay local, we can actually use that company to transport them to the nearest one, which would be like Vegas in our case. I haven't had to use it, so that's why I'm asking.
Sounds like nobody else has used it either, so that's something we can follow up on. We'll do some research on that and then provide some follow-up to that and see what we can find out.
And then I actually have another barrier that I recently came upon. Has anyone heard if Silver Summit and Better is anywhere close to getting a GI provider here locally? I know the closest one is in Vegas for them. And from what I know, there's the only way you can maybe get someone to see that patient here is if you go through a whole prior authorization, like coding and asking them, and then they still have to see if the patient even qualifies. They have to give like the actual case to a GI provider and see if they want to take them on. And I know GIC is not working with them for some weird reason. So has anyone heard of anybody taking the Silver Summit and Better insurance?
All right, so perhaps that's something for us to check as well. In Northern Nevada, we just have GI consultants primarily in Digestive Health Associates. So, do you know if Digestive Health Associates does anyone know if Digestive Health Associates takes?
They're not taking it. So Digestive Health Associates doesn't take it. GI Consultants doesn't take it, and Dr. Von Feldman with Northern Nevada Gastroenterology doesn't take it.
Well, we can check into that and see if there's anyone else. I would assume that they have a provider directory, and that no one's listed. But we can check on that too.
Yeah, they do. I checked the provider directory. All the ones that they have are in Vegas, and I talked to one of the representatives, and that's when I was told that what I could do is go ahead and do a prior authorization. It doesn't guarantee that the patient will be seen, but there's still a chance. But that's just a very lengthy process to do. And I know GI is not even bothering taking those prior authorizations. The only one that might work with them is Digestive Health, but I'm still waiting for that PA to get approved by Silver Summit and Better.
So really what one of the barriers is that the insurance plan hasn't contracted with any providers here, and the providers that are here aren't necessarily being cooperative in the process to at least get those patients screened.
Exactly. Yeah, so what I'm having to do is resort to the FIT test, but in this particular patient, he actually had a positive FIT test and no longer qualifies for the colorectal control program.
So he can't get a colonoscopy as a follow-up?
No. Patient is 68 years old.
Yeah, that's definitely a barrier. So he used to qualify for the colorectal screening program, and now he doesn't?
The colorectal cancer control program only qualifies for patients 50 to 64.
Oh, so he got the fit test, but he's not qualified to get the diagnostic screening in the program because of his age. Got it.
Yeah, well, he got the fit test because we couldn't find a GI doctor to see him for the colonoscopy because he has the Silver Summit and better insurance. And now that his fit test is positive, now he needs to follow up with the colonoscopy. But there's no local GI doctors. We would have to send him all the way to Vegas, and he can't exactly travel.
So we had a question here on this patient specifically. At 68, does he qualify for Medicare?
I think he went with the Silver Summit and better. I'm not sure if he would want to. I can check with him. Not really sure what the situation is or why he didn't qualify for Medicare.
Yeah, because if he did qualify for Medicare, that would be an option to get him coverage for screening. Here's a great question that I have as not working in a clinical setting is how many people have insurance like enrollers or insurance experts that they can refer patients to when they have challenges like this, challenges where their insurance isn't covering something and there might be a different option available to them for coverage. Are you guys able to generally refer people to someone like that within your clinical system to find options for covering this sort of thing, or is that generally left up to you as the care coordinators?
Yes and yes. So usually what I do with cases like that is I'll go ahead and refer them to Dr. Von Feldman. And the reason I refer to Dr. Von Feldman is because since he is his own practice, it's a private practice, he tends to be a little bit more flexible with the patient, and sometimes the payment options are more doable. Whereas digestive health and GIC, you just never know. There's just so many doctors and patients get lost, fall through the cracks because of how many doctors there are there. So that's kind of what I've been doing, kind of referring to Dr. Von Feldman and letting them know ahead of time that this is going to be a cash pay patient, that, their insurance might not be covering the actual procedure, but the patient needs to be seen or something needs to be done. And then, they'll go ahead and have the consultation, and then, of course, Dr. Von Feldman will decide what the next step will be. And I know there's a couple patients that have gone there and are very happy because of the cash payment assistance that he offers.
That sounds like a great option. I know that at Community Health Alliance, they've also formed partnerships with specific GI doctors to offer discounted or free colonoscopies as follow-up. Do any of our partners in Las Vegas have arrangements like that with physicians so that if they have a patient that encounters these barriers, they have that option with specialists? And it looks like we've got some comments as well on just a reminder of Nevada 211. I'm not sure if everybody has knowledge of that program, but it is a statewide program for resources and assistance. It's just called Nevada 211, and you have to pick up the phone and dial 211. And then they help direct people to services and resources to help them reduce barriers to really all sorts of different challenges that they may be facing. So medical challenges is just one area that they can assist with. So a reminder on that one. Yes, Sakai, I like the idea that you guys have reached out and formed a kind of a personal clinical relationship with a specific doctor who can work with you on getting some of the patient screens. I think that's personal relationships, I think, go a long way. So hopefully some of our other partners are also considering doing that. And I think that's can be a long process to kind of form those agreements with different providers. Does anybody else have any barriers that they'd like to throw in, or any thoughts on topics we've already discussed? Okay, I'm not seeing anything rolling in, but I think we've had some great conversation. I just have one more piece to add into this, and that is that we are closing out the fiscal year, which is kind of drawing to a close this first series of webinars. We are looking at topics to continue this series next fiscal year and beyond, and so I'd like to just solicit feedback from anyone on specific topics that you might like to see and learn more about in upcoming webinars. So feel free to share with me any ideas that you might have or things that you'd like to learn about. Ooh, working with insurance. I think that's a good one. I think we covered that today. Working with insurance. We'll put that down. Any other ideas? We did have a suggestion from one of our partners that wasn't able to be on this call related to discussing a patient's risk and including family history and potentially referring them to genetic counseling. Is that something that's of any interest to anyone? Oh, go ahead, Casey.
Oh, I was going to say I'm very interested in that, especially with for the breast cancer piece.
Okay. So we will add that one to the list. Any other topics that maybe you come up with in your daily work that you'd like to look at? It can be very hands-on. It can be very strategic. We are going to be updating the key messages webinar for colorectal cancer screening in the next month or two. The American Cancer Society originally created a handbook for communicating key messages to patients. Then they provided an update for key messages for Hispanic patients, and more recently they provided an update for key messages for Asian Americans. So we'll be adding in some of those additional key messages to the webinar that we created and re-recording that. It won't be a live webinar, it'll be recorded, so watch for that. All right, well, no other topics suggested. If you do think of any other topics, please feel free to email me. We want to make sure that these webinars are as useful as possible for all of you, and that we can provide information and resources to you that are going to help you in increasing cancer screening with your patients. We have additional cancer screening resources for you, and also resources for the community at nevadacancercoalition.org. Including on the cancer screening modules page, we do have links to videos, demonstration videos, similar to what Jessica had mentioned, having on her tablets, specifically to how to complete the FIT test. We have the different versions listed, and we have different languages, as well as how mammograms work, what happens during a colonoscopy. There's some great demonstration videos. So be sure to check that out. If there are resources that you're looking for that maybe we haven't created or you haven't been able to find but you think would be helpful to have in talking to patients, please feel free to reach out to us and we can see about creating those. Thank you everyone for joining us today on the call. And we've got one more hand raised. Maria, go for it.
Do they think you had a chocolate problem?
Maria, did you wanna jump in? All right, it looks like we might have lost Maria. So that's the end of our webinar for today. Feel free to email me at kristen@nevadacancercoalition.org if you have any additional follow-up. We will be sure to research some of the items that we discussed today and provide you with additional follow-up on what we have found. So thanks everyone for joining us, and have a wonderful end to your colorectal and Women's Health Connection fiscal years.